Hello, I'm Dr. Nicola Cooper. I'm a consultant haematologist at the Hammersmith Hospital and Imperial College London in the United Kingdom, and I'm here today with Jim Bussell.
I'm Jim Bussell. I'm a professor emeritus in pediatrics at Weill Cornell Medicine in New York City. And we're here to discuss about ITP. Nicola, I'm going to run through a little bit of the history first just to set the stage, and then turn it over to you.
Okay.
When I started in 1981, ITP was relatively simple. You took steroids or gave your patients steroids until you didn't want to anymore, or until they didn't want to anymore, and then pretty much you did splenectomy. And then in 1981, Paul Imbach came up with the use of IVIG in ITP, and that revolutionized ITP, making it clear that other therapies were very desired, that other therapies could be very desirable, and that even IVIG, with its very high rate of dramatic response, was not alone going to make it in the patient population because of the difficulties in getting it in the frequency that you needed it. So since then, as you know, because some of this we've worked on together, we developed IV anti-D, then there's the use of Rituximab, other treatments were tried, then the thrombopoietic agents, and now there's other agents in trial, including fostamatinib, which is a Syk inhibitor.
So Jim, do you think it's become easier to manage patients with ITP?
Actually, I think it's become harder. There's more choices and there's more to consider. And I think, I like to make the analogy to leukemia. In leukemia, all kinds of tests get done in the beginning. Patients are categorized into one of many, many groups, and then they're treated just for that group. This doesn't happen in ITP. In leukemia, once the treatment plan is started, it's planned out for the next year or two, and you're not supposed to deviate unless there's major problems. In ITP, no matter what the treatment plan is in the beginning, you could change it at any time if you or the patient wanted to make a change. So I think it's much more complicated than it used to be.
Do you think it would be an advantage to move towards a more kind of guideline-based treatment, or do you think we have the evidence to do that at the moment?
I think it would be an advantage, but I don't think we have the evidence. What do you think?
No, I don't think so. I think it's one of the things we tried to do in the guidelines that we published in the British Journal of Haematology this year, is try to have at least some kind of pathway for patients. So thinking about what type of patients they are, whether there's an infectious related disease, or say using your evidence suggesting that women of younger age might be more responsive to rituximab, so you can guide patients down that, but at least give physicians some kind of a pathway to follow if possible.
Why don't you throw in a little more specifics on that as to how you approach it?
So I guess we do, I think standard first-line therapy is still, unfortunately, IVIG or steroids. We don't have good evidence to change that practice yet. And then if patients fail that, if they don't go into an immediate remission, then we think about what type of ITP they have. So if it's related to an infection, HIV, hepatitis B, hep C, or if there's an association with immunodeficiency or immune dysregulation, ideally we go to a thrombopoietin receptor agonist, although that's not always very easy to do because of current funding restrictions. If they don't have any of those features, we try to go to MMF. So mycophenolate mofetil is a immunosuppressive agent that's very well tolerated. About 50% of people, I think, will respond to it, and it works quite well as a steroid-sparing agent. If patients don't respond to that or don't tolerate that, then we consider whether there's a autoimmune feature or high risk of thrombosis, in which case we would tend to go to rituximab. If not, we'll go down to a thrombopoietin receptor agonist. I think patients still then end up some patients end up on 2 or 3 of those lines, and that's quite frustrating to patients. And that goes back to what you said about ideally we'd have better biomarkers or indicators so we can classify patients into what kind of treatments they might respond to.
And so sometimes diagnostically, back in the beginning when you were saying infectious related immunodeficiency, you would have to do a fair amount of testing, at least blood
Yeah, we
tests.
do a
to
lot
get
of
that.
testing, absolutely. And I guess that's a slightly controversial area, but I think ITP is still a diagnosis of exclusion. So I think excluding all infectious causes, looking for any other autoimmune type features, I think is really important. And it does make a difference, I think, to what treatment strategy we should be using.
Yeah. Yeah, I think there are a lot of options, and you can try to individualize them for your patients, which hopefully you will do, but that also, I think, requires a lot of talking with the patient and trying to understand what's important to them. And I know you've been very interested in fatigue as something we'd like to fix. What do you think about that?
So I think fatigue is an issue for some patients, but not for all patients. It's quite a difficult thing to tease out fully. Some patients seem to think that they can tell what their platelet count is because of how tired they are. They haven't really got a full understanding about what platelet level that is. And I think for some people that gets better with treatment, but I think it's not clear to me. I don't know what you think about fatigue.
Yeah, I think it remains a disappointingly unclear area in that I think we and a number of other people agree, hey, this is really a problem, but don't quite know how to manage it, don't quite know how to expect if fixing the platelet count will or won't fix it.
Yeah.
And how, if you have it, that should alter, if it should alter what treatment you choose.
So Jim, I think Rachel Grace, on behalf of the ICON committee, presented some data at the American Society of Hematology on health-related quality of life issues in children. I wondered if you could comment on some of those results.
To be honest, I don't remember every detail perfectly, but I thought the thing that was encouraging was that in general, with a number of different treatments chosen in that study, seemed to improve with virtually all of them. I was a little worried about the fact that some of the groups, if the patient didn't respond, it looked like there were dropouts.
Yeah.
So I wasn't sure if that affected the results at all, but basically it was almost the first data outside of the TPO agents that suggested you could improve that.
Yeah. I think even psychologically for patients, a response makes them feel better. And I think you can't get away from the platelet count as something that does make patients feel better. If their counts are good,
Sure.
they psychologically feel better, I think. And I think responding to treatment makes a difference to patients. I think the patients who continually fail treatment, they feel psychologically quite sort of low about that, I think.
I agree. I'm sort of hoping maybe that avatrombopag will be a useful addition. There were 2 abstracts presented at ASH, one on ITP and one that was a combination of 2 randomized controlled trials that were pretty similar in liver disease to allow people to have procedures done. And both of them were pretty encouraging. I think the ITP one, the one that we would care about the most, or that people interested in ITP would care about the most, had very good results, which I thought supported what we had found in the original study that was published in Blood in 2014. So that may be a good addition because it's in a way like eltrombopag. It may or may not be more potent on a milligram basis, but it doesn't have any dietary restrictions.
And you mentioned earlier about the spleen tyrosine kinase inhibitor, the fostamatinib. Is there more data available for?
Well, there's some more data. I think if we take a overview of the data, there's about, give or take, a 20% stable response with a count consistently greater than 50,000. There may be another 20%, 25% who have a good but imperfect response where, let's say, the counts are consistently over 30 but not consistently over 50. And it looks like most patients on treatment maintain their response. So that part's pretty good. Where it'll fit in the overall treatment paradigm, I think we're not sure yet. It does have a little bit of GI side effects, including elevated liver tests, and also some amount of hypertension.
And the patients who were on those studies had chronic ITP, hadn't they? So had ITP for quite a long time. So.
Right. It was a median of more than 8 years for the patients on the 150 patients on the two identical parallel studies. So I think there'll be a question of the data is still being analyzed as to whether or not the patients whose duration of ITP was shorter did better.
So do you think there might be better response rates?
There might be, but the data to me thus far is not, the preliminary look at the data is not very convincing.
Yeah.
But I think we just need to see, because they haven't really broken it down so you could tell yet.
Okay, and talking about so Rituximab, I think you had some really nice data that you published, and Francesco Zayas also published data suggesting that some patients might be more responsive to Rituximab than others.
Yeah, we had copied Francesco by adding dexamethasone to Rituximab, and when we added 3 cycles, we thought that women who had ITP for less than a year when they were treated had a remarkably high rate of cure, like 3/4 or more, whereas all other groups, meaning men with any duration of disease and women with longer disease, might have very good responses for a year or more, but then would relapse and wouldn't actually be cured.
Yeah.
One of the things I'm curious what you think is that it's kind of a conundrum to me, because the better you make the ITP treatment, the more you increase the risk of significant immunodeficiency, including long-lasting hypogammaglobulinemia. So hard to me to know how to balance that. What do you think?
Yeah, I think that Rituximab's great if you're giving it once or if you're giving it every 3 years. I think I do have a cohort of patients who are now on yearly Rituximab and are starting to get infections, but for those patients, there's no other treatment options for them at the moment. I was concerned that perhaps we're making it worse in some patients, the ITP, by giving Rituximab, but I don't think we have the data for that. And I guess at the moment we still have options of treatment, and we don't have enough long-term follow-up for anything to know which one's the safest, I guess.
It's true. You heard Caroline Bennett and her collaborator talk about their 3 cases. What did you think of those?
So I think that hypergammaglobulinemia is rare. I think it's uncommon. I don't think it does not happen in everybody. Happens in a proportion of patients. I'm not sure we yet have the data to say which patients are going to do that. We certainly measure immunoglobulins in all of our patients before giving treatment. I think the cases that she discussed at the ICON meeting were children. And our practice at the moment is to go straight to eltrombopag for children with chronic ITP, because it's the only licensed indication. So we will definitely do that for children before giving Rituximab. So I guess we have a higher threshold for using Rituximab in children because of the possibility of long-term requirements for Rituximab, and also perhaps their B cells are less evolved. I don't know what you think about the hypergammaglobulinemia.
Yeah, I don't know. I was kind of hoping that if they could be explored genetically, that they would uncover some of the causes that would suggest that they would have evolved into CVID anyway, and the Rituxan was just making it happen earlier, in which case it would seem to me at least less bad if, as a price for treatment, they got IVIG, but I don't know how you feel about that.
Yeah, and I think, as you know very well, a number of the patients who present with common variable immunodeficiency as adults have had ITP or hemolytic anemia as a child. So for some of those children, I think it is a herald kind of sign for CVID anyway.
You were talking about the long-term treatment effects. I was going to mention a few things about the Extend study that was just published. I think...
the Extend study, what drug was the Extend study about?
the Extend study is the, quote, final results of the long-term open-label extension study of eltrombopag in adults with ITP. And I think that what was very nice about it was that there were a lot of new analyses compared to the interim long-term analysis that was published in Blood in 2012 or 2013, but overall was somewhat similar to the long-term romoplastin results also. Things that I thought were important were that something like 50 to 70% of patients had a very consistent long-term response, either better than a platelet count of 50,000 or a platelet count of 30,000 on an every 4 weekly basis. So that was very good. There is some bleeding, but primarily in non-responders. The doses seem to be fairly stable, not increase, and it appeared that relatively few people lost their response. Another thing that was really good, I thought, was that in looking at when people elevated their liver tests or when they had thromboembolic phenomena, that the liver test elevations that occurred were almost all in the first year. So if you got by the first year, you could feel pretty comfortable that nothing too bad was going to happen. And with the thromboembolic events, a lot of them were in the first year, though there was a tail out to 4 years. At a symposium I was at, there was discussion about that, and it had seemed clear that doing a workup for hypercoagulability in one study in the 15 patients in whom thrombosis was able to be tested for factor V Leiden and factors such as that, only 2 were positive for those, so it didn't seem worth doing a huge amount of testing. Another thing that came out was that it appeared that at least half the time the thromboses occurred when the platelets were less than normal, and in some of them when it was less than 50,000, and it wasn't particularly in patients whose count was above 400,000. So even though we worry about overshooting and thrombocytosis, I agree with what I think of as Francesco Rodighero's viewpoint, that when the count goes over 30 to 50,000, the people who may have thrombosis are the ones who would have had it anyway.
And what do you think about antiphospholipid antibody testing in the context of, do those patients have a higher risk of thrombosis, and would you change your decision on treatment based on that?
I've thought about that, and in theory that sounds like a good idea, and then you might say, or I might say, well, if they have it, then go more the immunosuppressive route, whether it's Rituximab-based or MMF-based or something like that. But in practice, I think there's a lot of antiphospholipid antibody tests, and it's not completely clear if one of them is positive, how meaningful that is. And officially, to make a diagnosis of antiphospholipid antibody syndrome, you have to wait months for the second one to know. So I'm not sure how practical it is. Plus, I know from studies we did a long time ago, actually with Charlotte Cunningham-Rundles, that IVIG has a lot of anticardiolipin in it. So if they've been treated with that anytime in the past few months, they might have a false positive.
Which kind of goes back to actually doing all of the investigations at the beginning. So I very much favour doing that before you give IVIG or something like that. And just sort of finally, I guess the other 2 points to raise are the bone marrow safety, and secondly about whether patients can come off treatment.
Well, first off, that with Walid Ghanima, we were really all over safety for years and did yearly or bi-yearly bone marrows as monitoring. And we ended up thinking that development of any kind of fibrosis, and we're just talking about reticulin fibrosis, not the kind of myelofibrosis you see in true myelofibrotic diseases. Seeing any even reticulin fibrosis of significance was very, very uncommon. There have been 2 studies from Novartis, one of which, the results of which were published in the Extend manuscript that was in Blood in October 2017, and I think it's pretty clear that that's not a major problem at all and probably does not require routine monitoring. And for trying to get people off, I guess if somebody's on a stable dose of romoplastin or eltrombopag and they have platelet counts consistently greater than 50, I would tend to think about trying to taper them a little and see what happens. How do you do it?
Yeah, I think that certainly for patients who've had quite tricky disease, I tend to keep them stable for a lot longer. And I'm very slow at reducing either romoplastin or eltrombopag. Sometimes I think the platelet count drops a little bit and then it comes back up again. So we drop it, see what happens, wait for things to change a little bit and then drop it again. Slowly, my experience of the patients who go into remission, they suddenly have a sudden rise in their platelet count, which I think I don't fully understand or can't fully explain. But they certainly do need fairly regular monitoring just to make sure they haven't suddenly gone into remission.
What do you think is going to happen going forward?
So I guess going forward, I think we have to understand better the place for all of the different agents that we have. I think we don't know where the position of the thrombopoietin receptor agonist or rituximab should be in that patient pathway. I think we need to understand the biology better, see if we can subcategorize patients into different groups, not just on their age or their gender, but possibly by their B cell or T cell type phenotype. And so we can target treatments better. It may be that we should be giving multiple treatments. So I think historically we've concentrated on the fact that 30% of adults will get better, so we shouldn't give them anything too toxic. But actually 70% don't get better, and perhaps we should be targeting more people to get more better, so finding more curative type treatments, which may involve combinations of treatment.
Maybe I missed it, but I thought you didn't mention doing genetics in them, like whole exome sequencing or doing that in studies and then trying to identify a number of genes and then looking at those specifically.
Yeah, I think that's a really exciting era of whole genome sequencing. And I think that as that gets cheaper, I think that's something we should do. We need to do in a very large cohort of patients in order to really be able to look at that. Requires a lot of complex bioinformatics, but certainly I think that's an exciting field, and hopefully will help us to guide treatment in the future.
Yeah, I was very excited in the Friday morning meeting we have to hear Jenny Despodovic present her stuff, because we've been waiting for it for a long time, and now it seems like it's close to 200 children with chronic ITP. It's really going to have the full whole exome sequencing, and meanwhile she's doing more patients and doing patients at diagnosis, and then a year later, whether they've been in remission or not, and doing RNA sequencing as well and looking for gene expression. So it could be that in the really bad children, they may not be that different from adults with chronic ITP. Should at least point the way as to what to do in adults, and I know you're hoping to do work in that area.
No, absolutely. I mean, I think the sort of whole genome sequencing has concentrated more on Mendelian type illnesses, so platelet production disorders, the thrombocytopenic patients. But I think having had that analysis and that data, I think we can move on to the much more complex, likely multigenetic causes such as ITP.
The other thing I think is very interesting is, I think if I'm not wrong, and maybe I'm wrong here, the last 3 really large ITP trials have all come out of China. And it seems to me that for whatever reasons, the government is pouring a lot of money into that field so that they're really able to do studies. And I know in the past, I can't speak for you, I was a little skeptical about the results, but I'm certainly not skeptical anymore.
I completely agree. And I think there's been a more alignment, I think, between the sort of Chinese, European and American groups, which sort of makes everything a lot more easily translatable. So a
lot of exchange of Chinese coming here, people like you or me or other people going to visit China.
No, I think that's changed a lot over the last year, even, in fact. I think, very much so. So I guess, would you like to summarize the points that we brought up today?
I think the points we've brought up today, the way I see them are, there is new information on a lot of treatments. We talked about eltrombopag, about long-term safety and efficacy, and the fact that haven't really seen new side effects to particularly worry about. Talked about Rituximab and the idea that with or without dexamethasone, it may do better in women with shorter-acting disease. We talked about the idea that while there's not a lot of recent studies on them, I think you like using MMF, and there's a lot of individual studies all supporting the use of MMF.
And just to say, we've in the UK, we're just about to do a randomised controlled study of MMF up front. Charlotte Bradbury's the CI for that.
Yeah, that'll be cool. And you brought up biomarkers, and I think that's really important because if we had any inkling up front about how somebody would do going forward long term, and maybe some of the genetic markers or other markers would help us with this, then we would know who maybe could be treated aggressively in the beginning to try to cure them before the immune response gets locked in via epitope spreading or whatever, versus who should be just babied along because they're going to get better and not have a lot of problems.
Well, it's been a pleasure to talk to you again today, Jim. I think we've covered quite a lot of ground in ITP, so thank you for being here and thank you for the discussion, and thank you all for listening.